So we're going to move on to our general session this morning. A few minutes a little late. I'm happy to introduce Phil Seo. Dr. Seo is an assistant professor at Johns Hopkins. He directs the vasculitis program there, and he's been working with many of us for many years. Expert in clinical care of vasculitis, does research in a variety of areas of vasculitis as well. And I'm glad that he's going to be talking about dealing with chronic medical effects of vasculitis, and this is purposely aligned with our next talk. So we talked a lot about, remember yesterday we talked a lot about trying to figure out what's active disease and what's damage, and we're trying to sort all of that out, and Phil's here to help think about things today, tomorrow, and down the line.
You're applauding. I haven't done anything yet. You guys are easy. So, good morning, everyone. I love doing that. It feels like I'm in church. So I wanted to let you know that I've taken care of patients exclusively with vasculitis now for almost a decade. Not quite, but getting there, which I realize is a drop in the bucket for some providers, but is a sizable amount of time. And what I was doing when I was putting together this talk was I was thinking about all of you. I was thinking about the patients I've met over those years and thinking about the things that we've talked about and the issues that have come up. And then suddenly I was hit by an insight. And it hadn't really occurred to me before, but it was something I wanted to share with all of you this morning. And I think it might get me in a little bit of trouble, but here goes. Having vasculitis sucks. Gosh, that feels good to say. And the reason why I think it applies to you more than it applies to most people with most diseases is because what I did was I sort of thought of all the stories I've heard over the years. And I came up with a compositive history of how you were diagnosed. So this is your story. Before I was diagnosed with vasculitis, I, A, never used to think about my health. B, was used to taking care of other people. C, could leap tall buildings with a single bound. And when I first developed signs of vasculitis, I ignored it. And the reason why you ignored it was because I thought it would go away. This sort of thing doesn't happen to me. Or my only natural weakness is kryptonite. So clearly the issue is that for many of you, vasculitis was the first major problem that you've had with your health. And you've gone from being someone who didn't really think about your health to someone who actually had to be an informed consumer. And certainly there are lots of things that can happen as a result of vasculitis. And I thought what we'd do is talk about some of those issues today. This is my list. I am planning on touching on all of these in varying amount of time, so I don't necessarily have an equal amount to say about each topic. I will also say that I'm originally from New York, which means that if you keep on letting me talk, I will start going at light speed. So if you start hearing me sound like Peter, what I want you to do is sort of wave your hands at me, and I'll slow down a little bit. Maybe just a little bit.
You wish.
The first thing I want to talk about is vaccinations. And I didn't really intend to talk about vaccinations first, but within the first hour I was in this conference, 3 people asked me questions about this. So I think someone's trying to send me a sign. So to talk about vaccinations, we're going to talk about this. Every day, we are exposed to noxious stimuli. And the question is, why aren't we always sick? And the answer is because you've got this brilliant immune system. And the way that your immune system works is it learns from its mistakes. So the first time that you get infected by a bacteria or a virus, your immune system fights it off. But in the process of fighting that thing off, it learns. So it learns to recognize what the problem is. So the second time it sees that virus or bacteria, it knows to attack it right on and just avoid the problem completely. Just sort of like my technique with channel surfing. So that first time on channel surfing, I might end up on the Jersey Shore by accident, and all of a sudden I watch the show and I get sick, right? And the second time I know better, so I just surf right past it and I get to ESPN, which is what I meant to do in the first place. So the brilliant thing about vaccines is it allows you to skip to step 2. So instead of forcing people to get sick first in order to learn about what the problem is with the bacteria or the virus, you can skip straight to step 2 and teach your immune system exactly how to act. Now, there are 2 different types of vaccinations. One's called inactivated, and the other one's called live attenuated. Now, the majority of vaccines are inactivated, which means that that the virus itself or the bacteria itself is not really present in a form that can cause a problem. We either kill the bug or we just take a little tiny fragment of the bug. I was thinking it's a little bit like Cinderella's slipper. It's not the entire girl, but it helps you identify the real thing when it comes by. Now, that's the majority of the vaccines. The other type of vaccine that you'll see, though, is a category called live attenuated. And what that means is it's a real bug. It really could cause an infection, except we hobble it a little bit. So we try to design it so it really can't cause the full-throated infection. But it's still a live thing, so we have to think about it just a little bit more seriously than we might otherwise. So again, the majority of vaccines are inactivated vaccines. And this has really revolutionized healthcare in a way that you probably aren't even really consciously aware of. So, for example, Haemophilus influenza B is a bug that you guys don't know about, but your parents and grandparents did because it killed off a lot of kids. And now we vaccinate everyone for this, and now we just don't see it anymore. It's basically a historical note. I could say the same thing about polio, that back in our parents' and grandparents' generations, everyone used to worry about their kids in the summertime, not knowing who would come away with polio. And now we don't talk about polio at all. And in the same way that we eradicated polio with vaccines, in the next generation, no one's going to know what cervical cancer is, because cervical cancer is caused by HPV, and now we're vaccinating everyone against that. So we're not going to see that anymore in the future. When we talk about live attenuated vaccines, even though they're the minority of vaccines, they represent a lot of important bugs like measles, mumps, and rubella, which again used to be commonplace in the United States and now have become vanishingly rare, except in California where they don't vaccinate everyone, but that's another discussion entirely. Yellow fever is an important one for those of you who are globetrotters. Yellow fever is an awful, awful disease that occurs in certain parts of Africa that you can avoid by getting the vaccine. Now, I don't want to talk about all these vaccines. The two I want to talk about today is the vaccine against the flu and the vaccine against varicella, because I think those are the most relevant to most of you. So let's talk about the flu. The first thing that's important to remember is that influenza kills people every year. And I think sometimes we forget about that because we talk about it so often and we use the word flu kind of interchangeably with just being sick. So I feel a little flu-y, I feel flu-like, I've got the flu, but we don't actually mean that you have influenza. But every year, influenza kills anywhere between 3,000 to 50,000 people. Remember that the majority of those people are going to be older adults, so those are the people who are at greatest risk. Remember also that flu season starts in the fall, but can extend way almost into summertime. So you're not quite out the woods yet when you get to December or January and you're thinking that maybe it's done. Now, fortunately, we have vaccines that work. So the first question is, who should get vaccinated? And the answer is everyone. So the recommendation used to be we just vaccinate people who are at high risk, so people who are on immunosuppressive drugs or older people. Now we just say everyone. So if you're older than 6 months, which should be the majority of you, you should get vaccinated. There are two small exceptions. The first one, if you're allergic to eggs, because eggs are used in making the vaccine, you can't take it. The second one is if you have a diagnosis called Guillain-Barré. If you don't know what I'm talking about, you don't have it, and don't worry about it. For the rest of you, though, you should get vaccinated. The second question is, when should I get vaccinated? And what I tell my patients is you should get vaccinated sometime between Halloween and Thanksgiving, because timing-wise, that works out about right, and it's pretty easy to remember. The important thing to remember, though, is you have to get vaccinated every single year. Getting vaccinated 2 years ago doesn't help you this year, because every year the flu virus changes a little bit. And what happens every year is the CDC sits down with their experts and they try to figure out exactly what we're going to see, and that's what they designed the vaccine against. So every year you have to get revaccinated to make sure that you have immunity against whatever version of the virus is coming up next. Some of you might remember the bird flu scare from several years ago, where it turned out the vaccine we generated wasn't against the right type of influenza, and a lot of people had to get revaccinated, so it actually is a serious concern. How should you get vaccinated? There's this thing called flu mist, which is an intranasal spray that they shoot up your nose. Tool of the devil. Don't use it. The reason why is because it's a live attenuated vaccine, so it's really a virus. So it could possibly give an immunosuppressed person an infection. That's a theoretical concern, and that's not really what I'm worried about. What I am concerned about is the fact that, one, it's more expensive, and two, it doesn't work as well as the shot. So if you got a choice, definitely go for the shot. The last question I always get asked is, but I'm on X. I'm on methotrexate, azathioprine, prednisone, whatever. That's not a problem for this particular vaccine as long as you get the shot, because remember, it can't give you the flu. Now, the one issue that you might run into is the fact that if you're immunosuppressed, you might not mount a full response to the vaccine. So that could be a problem, but you're not at any risk for getting the vaccine. So the next thing I want to talk about is Varicella Zoster, and for those of you who are fortunate enough not to know what that is, that's the disease that causes chickenpox. So 90% of you have had the chickenpox, whether or not you realize it. The interesting thing about the statistic is that many people don't really know that they had the rash associated with chickenpox, and yet if we test them, we can see that they were infected at some point. Now the reason why this is important is because even when the rash goes away, you still have the virus that lingers in your system. And that virus lingers around for decades until one day you wake up and you've got this new disease called shingles. Now shingles, also known as zoster sometimes, is what's described as a blistering rash. And that does not do justice to this, because the real problem with zoster is the fact that it goes after the nerves. So it picks a large group of nerves on one side of your body and it just attacks. And it gives you this awful pain that we call postherpetic neuralgia, which is a very cold term for something that's incredibly intense. And for some people, they liken to the pain at childbirth. Not having had either, I can't really speak to that, but that's what people tell me. Zoster is actually pretty common. It affects 1 out of every 1,000 people in the US, but those numbers go up with age. So if you're older than 65, it affects 10 per 1,000. And if you're older than 80, it affects 500 per 1,000. So you can see that as you get older, this becomes more and more relevant to your life. Fortunately, again, we have a vaccine against this. It is a live attenuated virus, meaning it's a real bug. It could really cause a problem, except we designed it so that it shouldn't give you the full infection. The good thing about this vaccine is it actually seems to be pretty helpful in a bunch of ways. The first is that it prevents some people from getting shingles. The second is even for people who do get shingles, it seems to make the course a little bit more mild or makes the problem with pain a little bit less. The third benefit is that sometimes it helps people from getting a second bout. Now that's the evil thing about this particular infection. Because in the case of most diseases, once you get it, you're not going to get it again. And that's not true with the shingles. Because for people who get shingles, 5% of you are going to get it again over the next 5 years. And it's possible that the vaccine might prevent that from happening. So who should get vaccinated? The American College of Rheumatology, which is my parent organization, recommends that everyone who's over 60, who's going to be immunosuppressed, should probably get this particular vaccine. This is where it gets a little bit tricky. So if you're on immunosuppression, which many of you are, you have to think a little bit harder. Again, this is a live virus, so you want to be a little bit more careful than you might be with other types of vaccines. So again, what the American College of Rheumatology says is if you're on methotrexate or azathioprine, you're okay to get it. If you're on low-dose prednisone, meaning prednisone lower than 20 milligrams a day, that's also okay. The big problem comes up for those of you who are on the fancy drugs. So anything that ends with mAb, like infliximab or rituximab or any of those biologic agents, you unfortunately cannot get this vaccine. It probably would be safe, but no one really knows, and no one's willing to recommend it at this point. Now this leaves open a big question for many of you, which is what if I'm not 60 years old? So the issue here is that it's only been approved by the FDA for people who are older than 50. So the chances of you convincing your insurance company to pay for this if you're younger than 50 is the chances of you getting an audience with the Pope. So it's possible, but it seems unlikely. And yet for some of you, it probably is a good idea, and I can tell you the field is thinking about what we should be doing for people who are younger than 50, but are probably going to be on immunosuppression for long periods of time, because I think many of you could probably benefit from this vaccine as well. So just to sum up, vaccines are good things. Most vaccines can't make you sick. We think a little bit about shingles, but that's more of a theoretical concern. The one I will point out, though, is yellow fever. Again, for those of you who go to Africa, this actually will make you sick. But it's so much better than getting yellow fever, it's worth it. But it's the one vaccine that I recommend on a regular basis that people don't like me for. But I'm warning you in advance. You need to get a flu shot every year. The flu shot you got 3 years ago at the fair doesn't count. You should get a zoster vaccine when you turn 60. And although not everyone says this, I think it's a pretty solid recommendation. Okay, so I'm going to move on next to osteoporosis. And I'm going to remind you that everyone should get a DEXA scan on a regular basis. And remind you that everyone gets another DEXA scan in 2-year increments. And the reason why we wait so long is because it's not a great test. So if I get a DEXA scan today and a DEXA scan tomorrow, it's going to look different. But it's going to look different in a way I'm not going to be able to interpret because the change is going to be so small, it probably won't really be significant. And yet I'll worry about it and I'll probably try to tweak something because that's what I do. So instead of doing that, what we generally say is that you need to get the DEXA scan repeated about every 2 years, because that's a good size of time, and that way the change that we see will probably mean something. The important thing for you to remember, though, is you want to go back to the same place every time. And the reason why is different machines give us slightly different results, and although that doesn't really make sense, it's possible that when you have a big swing on your results, the reason why is because your hospital just bought a brand new machine. And sometimes it's just hard to interpret the results if you keep on going from place to place. The last thing I'm going to say about that is that back, say, 5 or 6 years ago, we used to make treatment decisions based on the DEXA scan itself. So we would see a number, and based on that number, I would give you a drug. And now we know that that's not what we should be doing, because it actually doesn't help us with older people or younger people. So younger people can frequently have low bone density, and yet they don't have any risk of fracture at all, and they're absolutely fine even if I don't do anything. Whereas at the other spectrum, we know that some older people have perfectly normal bone density, and yet can have fractures all the time. So because of that, they developed something called the FRAX score, which the website for which is on this slide, and you can look it up if you like, but I swear it's easier to Google FRAX, because I can't remember what this web address is either. But the reason why I'm showing this to you is because if you take your clinical information, you plug it into this will tell you what your risk of fracture is and how worried you need to be. Now, I don't expect you to do this, but I think it's interesting to look at this because this shows you what the problems are and who might be at higher risk. So if you have a family history of having had a fracture, or if you've had a fracture yourself, you're at higher risk. If you drink or smoke, you're at higher risk. And of course, if you take steroids on a regular basis, you're at higher risk. The last time I spoke on this topic, this is what I told you. The National Osteoporosis Foundation recommends 1,500 milligrams of calcium every day. They don't say that anymore. And the reason why they don't say that is because there's been some research recently looking into people who take calcium supplements on a regular basis. And what they found, I'm sorry, excuse me for just a second. That's better. So what they found was that people who take calcium supplements in the absence of vitamin D may be at a higher risk of heart attacks. Now, other studies have looked at the same question and they've come with exactly the opposite point of view. And it's not really clear what the studies mean. But for the time being, a lot of groups have re-examined their recommendations about calcium and they've dropped them a little bit. So instead of recommending 1,500 milligrams of calcium, we're now recommending about 1,000 milligrams for most people. What we're also saying is that dietary sources are preferable. So the last time I spoke to you, I said there's no way on earth you can eat enough tofu to get all the calcium that you need. And now I'm backing off on that a little bit because the level of calcium that you need in your diet is now being rated a little bit less. So it's a little bit easier to get that just from food. Now most of you are going to get about 600 milligrams of calcium in your diet on a regular basis without even trying, which means that you probably will need a little bit of extra calcium in your diet, either by taking that extra portion of calcium-rich food or by taking a pill. These are some standard calcium foods and how much calcium they contain. All of them contain anywhere between 200 and 300 milligrams of calcium, so you can sort of think about your diet and what you eat and maybe what you should be eating differently. For those of you who need a little bit of extra help in order to get to that 1,000 milligram mark, you should know that calcium carbonate is chalk and therefore is the cheapest drug that you could possibly take. And yet for those of you who are taking a medication to suppress stomach acid like Zantac or the purple pill, you probably need to be on calcium citrate because calcium citrate is better absorbed when you're taking medications that lower your stomach acid. The other thing to remember about calcium is your body can only absorb about 500 milligrams of calcium at once, which is about the size of a pill. So if you take 2 pills at once, you're basically throwing one out because your body can't do anything with it. The last is remember that too much calcium is also a problem. From your standpoint, it makes you gassy. And that's a big problem from your standpoint. But from my standpoint, the problem is that it can give you kidney stones. It can also cause change in mental status. It can also cause other problems that you want to avoid. So you want to make sure that your calcium is a little bit higher than it is right now, but not too high. This is just a listing of common calcium formulations. CaCO3 is calcium carbonate, for those of you who slept through chemistry. I show you this slide just to point out that the brand names at the bottom, Viactiv and Citracal, those are the ones that advertise heavily, and you're paying for that advertising by giving the company an extra $4 or $5 for the pills, because the pills contain basically exactly what's in the cheaper drugs. So go ahead and buy the brand names if you like, but you're not getting any better calcium than you would if you get like Costco brand. So what else can you do besides taking calcium in order to decrease your risk of an osteoporotic fracture? The first thing they always tell you is you should decrease your steroids. Duh. like someone has to tell you that, but that's always the top of the list. The important thing that you can do is drink less and smoke less, which I'm sorry about, but decreases your risk of fracture because there's a correlation between those activities and the risk of fracture in the future. The other thing that's important is weight-bearing exercise. The more time you spend on your feet, the more signal that your bone gets that it has to get strong to support your weight, and the stronger your bones become. So the more time you can spend on your feet, the more time you can spend walking, the better your bones are going to be. There are lots of things about bone health that you can't really modify. If you're white or if you're Asian, your bones are going to be a little bit weaker. If you're skinny, your bones are going to be a little weaker, so. And again, if you have a family history of osteoporosis, your bones are going to be weaker too. So those are all things that you need to maneuver around when you're thinking about how concerned you need to be about this. Let's talk a little bit about memory, because the first thing that my patients tell me about a year after their diagnosis, I just can't remember where I put my keys anymore. Where did I put my keys? Why did I walk into this room? There are 3 things I was supposed to get at the store. I can never remember what the 3rd thing is. Memory issues come up a lot when I talk to my patients. And for you, I found this website. So this is a real website. I didn't make this up. And I did try to keep this family friendly, so I blacked out the word that some of you might find offensive. But if you're 12 years or older, what's underneath the star is exactly the word that you think is underneath the star. And the interesting thing about this website is if you click on the red button, it'll just keep on giving you more and more suggestions as to where you might have left your keys until, presumably, you find where your keys are. Now, the reason why I'm showing you this website is not because I actually expect you to use it, but because it just highlights how common memory problems are among all people, and not just people who've got vasculitis. Cognitive decline is common as you get older. For those of you who are younger and just smiling to yourself, stop smiling, because cognitive decline starts in your 20s, believe it or not. About 10% of people who are older than 65 will have what's called mild cognitive impairment. The good news is that means 90% of you won't, so that's great. The other thing is that the phrase mild cognitive impairment is one of those terms that's still not ready for prime time, because in some studies, if you diagnose a person with mild cognitive impairment, about 25% of the time you'll change your mind if you keep on following them. So it can't be that great of a phrase. But it is something that I think about because I think it comes up a lot in vasculitis patients. But in your case, I think the reason why it comes up is probably because of the effects of the drugs. I think steroids in particular wreak havoc on memory in general. But I also think it's common to have memory issues when you have a chronic illness. And if you look at people who've got other diseases, you'll see that people who've got cancer, for example, will talk about having chemobrain, and people who have fibromyalgia will talk about fibrofog. And it's pretty much the same thing that you experience on a regular basis. And I think part of the problem is that extra brain power that you used to use to remember the box scores for the World Series in 1986, you're now using to remember whether your appointment today is with pulmonary or with cardiology, or whether or not you have 2 refills on the prednisone or 1 refill on the prednisone. I just think there are only so many things you can stick in the bucket, so maybe it's not so surprising that you can't remember where your keys are on a regular basis. When it comes to preventing cognitive impairment, the thing that's important to remember is that the circulation that goes up to your brain is the same circulation that goes down to your heart. So whatever keeps your heart happy is going to keep your brain happy too. So you want to keep your blood pressure low, you want to watch your cholesterol, you want to get some exercise to improve your circulation, and you want to minimize stress as much as possible, which I realize is a pipe dream for some of us, but there you go. The other point is use it or lose it. People who do memory exercises on a routine basis, and this could mean crossword puzzles or Sudoku, you're going to hold on to your brain a little bit longer than people who watch Simpson marathons on a regular basis. So that's something else to think about when you're thinking about how to use your time. Now, none of this is going to tell you where I left my keys, right? So I'm going to tell you in my particular case, my keys are in my bookcase. And the reason why I remember that is because my keys are being held by Cookie Monster. So Cookie Monster is sitting on my bookcase, and he's holding a cookie in his left hand, and he's holding my keys in his right hand. And I'm telling you this little story for a reason, but I'll mention it in just a little bit. Because in the meanwhile, what I want to talk about is coping strategies, because all of us are going to have memory issues at some point, and I think that the key here is just to learn how to deal with it. So the first thing I always tell people whenever they're diagnosed with vasculitis is just go to the Staples and invest in Post-it notes, because you just have to write things down. The more you write things down, the less you're going to be worried about forgetting things, the easier it is to go through life. I just think that just taking notes on a regular basis is a good idea. I also think that ribbons actually work. People used to say tie a ribbon around your finger. It actually works. I've actually done this, and it actually helps you remember, because every time you look at the ribbon and you think, why on earth do I have this stupid ribbon around my finger? You remember that you're supposed to pick up the kids, or you're supposed to get the roast, or whatever it is you're trying to make sure that you don't forget. The second thing is the value of autopilot. So instead of trying to remember where your keys are, maybe you should just put your keys in the same place every single time, right? So put a bowl next to the door. Every time you go home, you pull the keys out of your pocket, put it in that bowl. That way you always know where your keys are. And if you can just train yourself to do things in a predictable way, you won't have to rely on your memory quite so much. The last concept is something called a memory palace. And some of you might have seen like quiz shows or something where they have a deck of cards or they have a list of numbers and they show them to the person and they just rattle off all the cards in order. And the way they're doing that is they're constructing what's called a memory palace, which is they're using their visual memory to try to remember something that's otherwise really hard to remember. So maybe they're thinking about a place that they know really well. So I'm thinking about my house, and at the front door I see the Jack of Spades taped to the front door. I open that front door and I have a knocker, and underneath that knocker I have the 8 of diamonds. And I open up the door and I look down on the floor and I see the 6 of diamonds and the 7 of diamonds. I look to the left and I see my staircase, and that's where the Ace of Spades is. And by using my memories that I already have firmly fixed in my head, I can attach that to new memories to try to remember where things are or what lists are or anything that I'm trying to keep in my head. And professionals, people who do this for a living, believe it or not, they spend a lot of time trying to create these very complicated visual images so they can remember very long lists. But for you, you don't really have to do that. Because I'm betting at least some of you remember where my keys are, which is where? Cookie Monster's holding them because Cookie Monster's sitting on the bookcase, so maybe it wasn't that hard after all. The next thing I want to talk about is pain, and I'm not going to spend any time talking about drugs. I'm just going to tell you that the drugs don't always work, which all of you probably know. So for some of you, you twist your ankle, you slip and you fall, and you take a couple of pills and you're okay, and God bless you, that's great. But for those of you who have chronic pain, especially neuropathic pain, the type of vasculitic damage that you get in your feet, you know that the drugs just kind of cover up the symptoms, and they never really make you completely right. I think the mistake that we've learned over the years is that we always try to just treat people for their pain rather than try to teach people to cope with their pain, and that's kind of what I want to talk about now. I have a good friend who says things like this on a routine basis. Like, turn that frown upside down. And every time he says that, I have the same impulse. I want to smack him really hard. And because I know that about myself, I would benefit from cognitive behavioral therapy. Now, cognitive behavioral therapy is not saying that pain is in your head. What it is telling you is the way you think about the pain affects how it affects you. And that you can actually retrain yourself to interpret pain signals in a different way that makes it a lot more manageable. And maybe it's not all that you need, but it certainly helps. Cognitive behavioral therapy, unfortunately, in the United States is not commonly covered by insurance. And for those of you who are interested in exploring this, there is a website out there based in Australia that actually takes you through a lot of these concepts, and I recommend it to you. I will say that those of you who get to the website and think it's a waste of your time are probably the most likely to benefit from it, just because that kind of those personalities who actually like this sort of stuff are not the sort of personalities that need it. So I recommend that if you find this frustrating or irritating or juvenile, just stick with it. The other thing I'm going to mention is this website, which is fibroguide.com. This was constructed by a colleague of ours in the University of Michigan who specializes in fibromyalgia. But it actually has a lot of good suggestions for dealing with all sorts of chronic issues. And what he recommends is that while you're reading it, just delete the word fibromyalgia and stick in whatever your diagnosis is, and you'll probably find it equally helpful. The other thing I'm going to recommend is Tai Chi. And the first 100 times I said this out loud, I felt like a dolt, because it really sounds like this new agey thing that I'm trying to pass off on you. And yet this is the New England Journal of Medicine, which is a pretty big journal in medicine. And they published an article that demonstrates that doing Tai Chi on a routine basis improves pain associated with fibromyalgia. And fibromyalgia pain is actually traditionally pretty refractory to treatment. So this is a significant finding. In the same way, yoga actually helps a lot of people. I know a lot of you have discovered yoga on your own because it's the most commonly used form of alternative medicine in the United States. But there are lots of studies that demonstrate that people who do yoga on a routine basis have lower levels of pain. And it might be because it induces endorphins, which are sort of the natural version of morphine that your body produces. It also promotes relaxation, but regardless of why it works, it seems to help a lot of people. So when I was in medical school, I was taught that I should keep on giving you pills until you don't have any pain. Now I know that if I do that, many of you will stop breathing. That is not the goal. I think that pain medications help take the edge off, but I don't think they get you all the way to where you need to go. And I think things like Tai Chi, yoga, and cognitive therapy are really helpful adjuncts to help you cope with pain and get it to a level where you can live with it on a regular basis. Now, I did have one more topic I was going to talk about, but I realize I'm running over. And apparently we have a session on fatigue. So I think I'm going to stop there, but thank you very much for your time.